Hi, everyone. Glad to see you've joined today for our August webinar. We'll wait another moment before starting. Good afternoon. I'm Keisha Bohannon, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of CDC's One Health Office, welcome to the August 6th, 2025 ZOHU Zoonoses and One Health Updates call. Next slide, please. Although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Links to resources from each presentation are available on our website at cdc.gov/1-health/PHP/trainings-events/August-zohu-call.html. Next slide, please. Today's presentations will address one or more of the following 5 objectives. 1, identify an implication for human, animal, and environmental health. 2, identify a One Health approach strategy for prevention of public health threats. 3, identify a One Health approach strategy for detection of public health threats. 4, identify a One Health approach strategy for responding to public health threats. 5, list 2 ways to improve collaborative practice across the public healthcare team. Next slide, please. In compliance with continuing education requirements, all planners and presenters must disclose all financial relationships in any amount with ineligible companies over the previous 24 months, as well as any use of unlabeled products or products under investigational use. CDC, our planners and presenters wish to disclose they have no financial relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Content will not include any discussion of the unlabeled use of a product or product under investigational use. CDC did not accept commercial or in-kind support for this activity. Next slide, please. Instructions for receiving free continuing education are available at cdc.gov/1-health/php/zohu/index.html. To receive free CE for today's webcast, sign in or create an account at train.org by September 8th, 2025. The registration code is ZOHU Webcast. A captioned video of today's webinar will be posted on our August call page within 30 days. And free CE for the web on-demand video of today's webinar will be available until September 9th, 2027. Next slide, please. Before we begin today's presentations, CDC's One Health Office Fellow, Dominic Cristiano, will share some news and updates.
Thanks, Keisha. Good afternoon, everyone. Thanks for joining our August ZOHU call. We're really happy you're here today, but as always, please share the ZOHU call website link with your colleagues from public health, agriculture, wildlife, plant, environment, and other sectors so we can let them all know about the live and recorded webinars and free continuing education that the ZOHU call offers. Before we start our presentations, we'd like to share a few monthly updates and resources with you. You can find links to these resources in today's ZOHU call email newsletter. And if you aren't subscribed to that newsletter yet, you can sign up using the link on our main ZOHU call webpage so that moving forward, you can get these updates. You can find the latest H5N1 bird flu updates on CDC, USDA, and FDA's websites. These include situation updates, recommendations for protective actions for people, and confirmed cases in domestic livestock, poultry, wild birds, companion animals, and more. CDC is also working closely with partners to respond to an outbreak of New World screwworm in Central America and Mexico. You can find the latest updates on USDA and CDC's website. Next slide. CDC has developed a short survey to better understand backyard poultry owners' views about bird flu. CDC will use the survey results to improve H5 bird flu prevention activities. The QR code on the screen here will take you directly to the survey page. You can also type in redcap.link/backyardflock to access the survey. Please share this survey widely with your One Health partners. Next slide, please. In today's newsletter, we highlight several recent publications, including a publication highlighting the emergence of clade 1B monkeypox virus, and an article from the Lancet One Health Commission titled Harnessing Our Interconnectedness for Equitable, Sustainable, and Healthy Socio-Ecological Systems. Next slide. The newsletter also highlights recent announcements and resources, including keynotes from a discussion at Cornell University titled One Health, Fish Edition, Biodiversity, Health, and Nutrition Through an Aquatic Lens, a webpage from the Environmental Protection Agency on protecting water quality, a web resource on preventing the spread of flu at local fairs, as well as links to the alpha-gal syndrome website to help share the latest updates on what alpha-gal syndrome is and how to prevent, diagnose, and manage it. Look out for new images and resources. Next slide. Here's some August observances that may be of interest to you. The month of August is National Immunization Awareness Month, as well as National Water Quality Month. Next slide, please. And finally, we've shared several new and ongoing outbreak investigations, including a salmonella outbreak linked to frozen sprouted beans, another salmonella outbreak linked to pistachio cream, another salmonella outbreak linked to backyard poultry, and another salmonella outbreak linked to geckos. There is an ongoing listeria outbreak linked to chicken fettuccine Alfredo meals. You can visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past U.S. outbreaks of zoonotic diseases. And linked from today's newsletter, you can find details about additional ongoing U.S. outbreaks. Please do continue to send presenter and topic suggestions for future presentations, as well as news from your organization to zohucall@cdc.gov. Next slide, and back over to you, Keisha.
Thank you, Dominic. You may submit questions at any time using Teams Q&A feature. Please include the topic or presenter's name in your question. The Q&A session will follow the final presentation if time permits. You may also email questions to today's presenters. We've included their email addresses on this slide and into today's email newsletter. Next slide, please. Our first presentation, You Oughter Be Kidding Me, One Health Investigation into Tularemia from Marine Mammals, will be shared by Dr. Hannah Oltien and Diana Lambourne. Please begin when you're ready.
Hi, I'm Diana Lambourne, and I work for Washington Department of Fish and Wildlife, and I am a marine mammal research biologist and a licensed veterinary technician. I have been working with marine mammals for over the last 30 years plus. Next slide. Just touching on the human health risks for zoonotic exposure for marine mammals and touching on the people that may be exposed to marine mammals, which run the gamut from researchers working with marine mammals, stranding network responders, rehabilitators, marine mammal trainers, veterinary staff, laboratory workers, subsistence hunters, fishers, and other people coming into contact with marine mammals, volunteers within stranding networks. There other sources of exposure with the public can be swim with dolphin programs and tourists, and also recreationalists such as open water swimmers. Next slide. Just giving a brief background in the marine mammal stranding networks in the United States. The marine mammal stranding networks are managed by 2 federal agencies. The NOAA Fisheries manages the stranding network that is responsible for whales, dolphins, seals, and sea lions. And the U.S. Fish and Wildlife Service manages networks that include managing species such as sea otters, manatees, polar bears, and walruses. The stranding network is composed of cooperating scientific investigators, universities, nonprofit organizations, rehabilitation centers, zoos and aquarium, fish and wildlife agencies, and other state, federal, and tribal agencies. Next slide. And I have included a list of some of the potential zoonotic marine mammal diseases that we have found over the years. And I'm not going into depth in these slides. They will be made available, but I have included in these lists documented exposures to people either working or exposed to these confirmed cases exposed to marine mammals. And this is a list of the bacterial diseases on this page. And then next slide. And this table includes the viruses, the funguses, and the parasites of concern that we have documented in marine mammals, some of which that have had confirmed exposure and have been transmitted to people. And this is a table that has been adapted by a publication from Waltex et al. 2012. Next slide. So I was kind of asked to give some hindsight, and this is my advice to my younger self and other wildlife workers. Risks are real, and we continue to learn more about marine mammals and their diseases every single day. Just a reminder to treat all wildlife, especially dead and sick and injured wildlife, as potential disease risks. And also establish a good relationship with your physician and create this discussion about the potential marine mammal diseases and zoonotics that you may be exposed to as part of your work. And this one I find to be the most important, that I have kind of developed as a mantra when it comes to your health, is just make sure that you're advocating for yourself when it comes to, potentially exposure to these diseases. And if you can't, make sure that you have someone that can advocate for you. And again, just a reminder of don't drink, eat when working with marine mammals, wear PPEs, wash your hands, hold hands when crossing street, don't run with scissors, etc. Next slide. And this is the insight that we have. And over the last 30 years that I have been working in marine mammals, we have discovered a multiple of new pathogens with potential implications to environmental, animal, and human health. We have engaged in many collaborations with multiple entities, including federal, state, nonprofit organizations, universities, and others, working through better understanding these pathogens. But with the recent work that we have been doing, working with Department of Health and human health experts, it has helped provide a broader One Health perspective and novel insights, and definitely has helped connect more dots in this process. Next slide. And then any questions, but from my understanding, the questions are going to be held till the end. Thank you.
Thank you. You can go right in, Dr. Olteen.
Hi, good afternoon. I'm Hannah Olteen. I lead the Zoonotic and Vector-Borne Disease Program at the Washington State Department of Health, and I'll be expanding a bit on our recent investigations into tularemia from marine mammals. Next slide. On November 3rd of 2023, an isolate arrived to the Washington State Public Health Laboratories for rule-out tularemia testing. A standard public health investigation was initiated, which identified a previously healthy 32-year-old woman residing in Kitsap County, Washington. This patient was first evaluated for a painful swelling on her left hand approximately 2 weeks previous on October 20th. This patient worked as a wildlife biologist for a nonprofit organization, which was part of one of the marine mammal stranding networks that Diana just mentioned, and reported that on the previous month, on October 3rd, she had nicked her finger with a scalpel while performing a necropsy on a harbor seal that had been found deceased along South Puget Sound. Although her wound initially appeared to heal, it became inflamed and painful 2 weeks later. Around this time, the patient experienced onset of fever and lymphadenopathy, as well as cough and congestion. Although tularemia was not suspected by the provider at that time, the wound exudate was cultured and Francisella tularensis was isolated and confirmed by the Washington State Public Health Laboratories. Next slide. This was a very unusual finding, as tularemia had never before, to our knowledge, been associated with saltwater or marine mammal exposures. Notably, a second volunteer who had participated in the same seal necropsy did not report symptoms of tularemia. In Washington State, tularemia is relatively rare, with a background rate of 1 to 10 cases reported annually. Among these reported cases in Washington State, the majority are exposed through disturbing or handling sick or dead rodents or logomorphs. Classic exposures include running over rabbit carcasses with a lawnmower or squirrel bites. Next slide. Because tularemia was not previously associated with marine mammal exposure, Kitsap Public Health District investigated to determine all possible exposures, initially with a focus on environmental contamination of the wound at home or at work. The individual reported living on a rural property and also working in a second animal care setting where they handled feeder rodents. Contact with the second workplace was initiated to identify any sick or recently deceased animals or other possible exposures. Next slide. Simultaneously, the Washington State Department of Health worked with the Washington State Department of Fish and Wildlife to identify the harbor seal carcass and collect and submit specimens to the Washington Animal Disease Diagnostic Laboratory, or WADL. On November 17th, 2 weeks after the clinical isolate from the human patient tested positive for Francisella tularensis, multiple tissue specimens from the harbor seal resulted preliminary positive for the same organism at WADL. Specimens forwarded to CDC Fort Collins were subsequently identified as Francisella tularensis type B subspecies holarctica, which was phylogenetically similar to type B strains previously found in the western United States. This finding represented the first known detection of Francisella tularensis in a marine mammal globally and was published in MMWR last year. Next slide, please. Fast forward just over a year to January of 2025, when a stranded sea otter and a stranded harbor seal were collected through the Marine Mammal Stranding Network and necropsied on January 14th. On January 22nd, the Washington State Department of Health was alerted to a preliminary positive result, this time for avian influenza, from the harbor seal. Department of Health initiated public health response to an avian influenza detection, including local health jurisdiction assessment of people potentially exposed to avian influenza through handling the harbor seal. 2 people reporting symptoms consistent with influenza were identified, but urgent testing ruled out influenza in both. All other persons who had handled the harbor seal completed their symptom monitoring for avian influenza on January 27th, with no additional illnesses reported. Next slide. On Friday, January 31st after hours, Department of Health received notification from Waddle of detection of Francisella tularensis by PCR from tissues collected from the sea otter. On February 1st, 3 people were identified with exposure to the sea otter, including the same 2 individuals previously identified as ill and testing negative for influenza, one of whom was hospitalized with severe disease, including pneumonia. The local health department facilitated transfer of a clinical isolate for this person to the public health laboratories, where it was positive for Francisella tularensis by PCR on February 5th. The second ill individual reported seeking care at an emergency department for chest pain and shortness of breath, among other symptoms. Tularemia testing for this individual confirmed seroconversion for antibodies to Francisella tularensis. Specimens from both the sea otter and the culture-positive human case were confirmed at CDC and sequenced, representing then the second detection globally of Francisella tularensis in a different marine mammal. Next slide, please. Public health investigation in this case included patient interviews, medical record reviews, and a site visit to the necropsy laboratory to identify areas of improvement in infection prevention and control. PPE use during necropsy was reported to include gloves, surgical masks, and personal eyeglasses. The site visit documented limited ventilation in the laboratory space. Because occupationally associated cases of disease were identified, the Washington State Department of Labor and Industries was also alerted and conducted a separate compliance investigation. Washington State Department of Health met with the Department of Labor and Industries to discuss findings and share resources. Next slide, please. Information regarding these investigations was shared with NOAA, who presented information on zoonotic diseases of concern at a monthly meeting for West Coast stranding partners. The Washington State Department of Fish and Wildlife presented information on these detections at national meetings, as well as distributing information internally to staff. While additional recommendations from Public Health and Labor and Industries were pending, Washington Department of Fish and Wildlife updated their internal PPE guidance for necropsy and switched out all surgical masks in the laboratory for N95 respirators. Department of Health had previously worked with Department of Fish and Wildlife to develop and co-brand a medical alert card for people working with wildlife. This card was reprinted and distributed. Next slide, please. To better understand the landscape of recommendations and resources for disease prevention among people working with marine mammals, we met with experts from 7 agencies or organizations, both within the U.S. and internationally. These experts provided a variety of opinions, protocols, and resources, which were referenced in the development of a letter of recommendations for Department of Fish and Wildlife. Key resources used to develop follow-up recommendations included the NIOSH Health Hazard Evaluation conducted at a marine mammal center, the USGS Field Manual of Wildlife Diseases, the National Park Service Safe Work Practices for Employees Handling Wildlife, the CDC Brucellosis Reference Guide, the NASPHV Compendium of Standard Veterinary Precautions, and the Veterinary Information Network Design Considerations for Necropsy Facilities. Prior to delivery of a formal letter of recommendations to Department of Fish and Wildlife, we met with veterinarians and staff biologists there to discuss the practicality of our recommendations and refine according to their lived experience and expertise. Moving forward, we plan to work alongside the Washington State Department of Fish and Wildlife to identify and develop resources that are yet needed, including donning and doffing posters for the laboratory and training materials for staff. Next slide, please. These overlapping investigations point to a need to think more holistically about wildlife exposure settings to ensure disease prevention. Efforts in Washington for One Health real-time data sharing and response have improved our ability to identify and respond in such situations. However, ongoing work is needed to move our focus from a single sector or pathogen to integrated infection prevention. Infection prevention and control in veterinary and animal settings has not historically been addressed or treated as it has in human healthcare settings, and there are real barriers to implementing such protections that would lead to the highest level of protection for people interacting with mammals, such as outdoor elements, gross contamination, very physical tasks due to the size or behavior of animals, and more. However, there is a shift toward addressing this human-animal health interface from more of an IPC perspective, with new work coming out of APIC and elsewhere on this topic. Ongoing One Health coordination is necessary to ensure pragmatic and useful recommendations in this space. Next slide. With that, I'd like to acknowledge the many collaborators on these investigations, including staff from the Washington State Department of Health and our Public Health Lab, Kitsap Public Health, Snohomish Public Health, the Tacoma Pierce Health District, Washington State Department of Fish and Wildlife, our Animal Disease Diagnostic Laboratory, and CDC. Thank you.
Thank you so much for sharing, Diana and Dr. Oteen. Our next presentation, Occupational Exposure to Animals with Tularemia, will be shared by Dr. Laura Platt. Please begin when you're ready.
Hi, good afternoon. I look forward to speaking with you all today about occupational exposure to animals with tularemia. Next slide, please. Tularemia is a rare, potentially fatal disease caused by the bacterium Francisella tularensis. Next slide. Francisella tularensis has diverse modes of transmission, and humans can become infected through tick or deer fly bites, handling infected animals, ingesting contaminated water or meat, or through inhaling contaminated dust or aerosol during activities such as mowing. Next slide. Tularemia has diverse clinical manifestations that vary depending on the route of exposure. Some of these manifestations include a cutaneous ulcer, swollen lymph nodes, pharyngitis, and the most severe presentation is a pulmonary infection that typically follows inhalational exposure. Tularemia can also present as a nonspecific febrile syndrome without localizing signs or symptoms. Next slide. As you can see from this map of reported cases of tularemia in the United States from 2011 to 2022, cases most commonly occur in the central United States, but have been reported in nearly every state. Next slide. Our colleagues in Washington did an excellent job describing potential occupational exposure for wildlife biologists interacting with infected marine mammals, although a more common scenario is tularemia from veterinary occupational exposure. Next slide. Following a case of tularemia in a veterinarian after a needle stick injury, our group collaborated with 4 state health departments to summarize the results of a survey that was administered to better understand veterinary occupational exposures to tularemia. This allowed us to learn about the circumstances and outcomes of 20 exposures that took place from 2012 to 2022. Next slide. With these exposures, the individuals who were involved included veterinarians, veterinary technicians and assistants, and office administrators. About 80% of the exposures were from cats and 20% were from dogs. And approximately a third of the exposures, they were considered to be high risk with contact to infected fluids without standard use of PPE. And overall, PPE use was uncommon and not used at all for 80% of the investigated exposures. Next slide. Following these exposures, approximately a third of people took prophylactic antibiotics to prevent infection. Most of the people who elected to take antibiotics had low-risk exposures. And in follow-up, no one developed clinical signs or symptoms of tularemia. Next slide. From these survey results, we learned that exposures to animals with tularemia is not uncommon, although the use of personal protective equipment is not routine. And we also found that response to exposures is highly varied, with some opting to take prophylactic antibiotics. Next slide. In addition to learning about cases of veterinary exposure to tularemia through the study that I just described, our branch at the CDC often hears about cases through public health inquiries. And specifically, we're often asked to assist with, next slide, assessing the level of risk of an exposure and discussing the role of post-exposure prophylaxis. Next slide. Historically, these types of questions were best addressed in our guidance for laboratory workers, but we are updating this information to address broader occupational exposures, including animal exposures for veterinary staff and wildlife biologists. Next slide. Regarding risk assessment and mitigation, we advise that higher risk exposures include needle sticks or scalpel injuries when handling infected animal specimens, bites or scratches from infected animals, or inhalation of aerosols, for example, with bone saw use during necropsy. Risk can be mitigated by wearing recommended PPE, including respirators during aerosol generating procedures. And we refer to the Compendium of Veterinary Standard Precautions produced by NASPHV to describe recommended PPE use. Next slide. Following an exposure to tularemia, management options include fever watch or post-exposure prophylaxis. Fever watch entails a worker monitoring their temperature for 14 days and seeking immediate medical evaluation if a fever or other symptoms of tularemia occur. And post-exposure prophylaxis includes 7 to 14 days of antibiotics. Fever watch may be preferred for lower risk exposures if greater time has elapsed since the exposure, or if there is greater personal concern regarding potentially unnecessary antibiotic use. Post-exposure prophylaxis may be occurred for higher risk exposures if minimal time has elapsed since the exposure, or if there is greater personal concern regarding potential infection. Next slide. While discussing antibiotics for post-exposure prophylaxis, I wanted to take the opportunity to share that updated guidelines on the treatment and prevention of tularemia will be released in MMWR shortly. Next slide. These guidelines will include an updated table of antibiotics for post-exposure prophylaxis for adults potentially exposed to Francisella tularensis. And the text of the document will include notes that highlight that the risk of transmission from animals to workers in routine veterinary care is low. However, PEP or post-exposure prophylaxis can be considered after high-risk exposures. Next slide. Thank you.
Thank you, Dr. Platt. We'll be looking out for that MMWR and updated guidelines. I'm sure we'll be sharing when it's released. Okay, our final presentation, Time to Talk Ticks, Ehrlichiosis in the United States, will be shared by Dr. Joanna Sauser. Please begin when you're ready.
Yeah, thank you. So I'm Johanna Sauser. I'm the epidemiology team lead for the rickettsial zoonoses branch at CDC. And thank you for having me. So next slide. Ehrlichiosis, human ehrlichiosis is nationally notifiable in the United States, and it's caused by 3 different species of Ehrlichia. So Ehrlichia chaffiensis and Ehrlichia uinii are transmitted by the Lone Star tick, and the geographic distribution of human cases largely mirrors that of what we know where Lone Star ticks occur. Next slide. And the third one, which is even less common, is Ehrlichia maris ocularensis, which is transmitted by the black-legged tick, or Ixodes scapularis. And despite the fact that this tick has a fairly large geographic range, human cases have primarily been isolated to only Minnesota and Wisconsin. Next slide. The incubation period for ehrlichiosis from time of tick bite to first symptom onset has a 9-day median. First symptoms include fever, headache, myalgia, and anorexia. Patients can experience GI symptoms. On clinical labs, you can see leukopenia, thrombocytopenia, and elevated liver enzymes. And about a third of patients will develop a rash, but after day 5. And the rash can vary from petechial and maculopapular to a more diffuse erythema. The rash is usually isolated to extremities and trunk. And some patients, though, the symptoms will be mild enough that they may not seek care. Next slide. But of the cases reported to CDC, over 50% are hospitalized. And so some of the more severe presentations include a meningoencephalitis, myocarditis, and renal failure. The case fatality rate is approximately 1 to 2%, with the risk of death greatest in children and older adults. There have been transplant-associated cases, and in the last 2 years, we've seen a little bit of an uptick of these cases at CDC. And laboratory confirmation can be done one of two ways. So using PCR, looking for Ehrlichia, a broad Ehrlichia genus, or species-specific PCR that will be able to differentiate between UNEI chafiensis and Ehrlichia marsocorensis. And then the gold standard laboratory confirmation would be the fourfold rise in serologic titer using an immunofluorescent assay. Next slide. Ehrlichiosis in the United States is thought to be broadly caused by Ehrlichia canis, which is transmitted by the brown dog tick. And the map here is all yellow because you can pretty much find this tick anywhere where you can find dogs. Ehrlichia chafiensis and Ehrlichia unii, though, has also been associated with canine ehrlichiosis. And interestingly, Ehrlichia unii was actually first identified as a pathogen of dogs before identified as a pathogen of humans. Next slide. Clinical features of canine ehrlichiosis caused by Ehrlichia canis can present in these acute, subclinical, or chronic phase. And acute symptoms include fever, anorexia, thrombocytopenia, and dogs can present with stiffness and a reluctancy to walk. Findings include enlarged spleen, lymphadenopathy, and a rash may not be present, and if present, it sometimes can be hard to observe. Chronic phase of ehrlichiosis, when acute phase is left untreated, includes uveitis, neurologic signs, and renal failure. Fatal cases are most often associated with a pancytopenia. Next slide. The good thing is ehrlichiosis is easily treatable with doxycycline. So doxycycline is recommended for treatment of ehrlichiosis in humans. Next slide. As well as treatment in dogs. Next slide. And doxycycline is used for humans and dogs and is safe for all ages. Next slide. I'm going to talk a little bit about the epidemiology of human ehrlichiosis in the United States. Next slide. We've seen an increase of cases of ehrlichiosis over the last 2 decades. As you can see here, we've seen a steady increase until 2022. With the COVID-19 pandemic, we saw a drop in cases, but we're starting to increase again. Majority of these cases are associated with infections from Ehrlichia chafiensis, although with an increase in the use of more species-specific PCR, we're seeing an increase in Ehrlichia unii and Ehrlichia marsocorensis. Next slide. This graph shows the seasonality of symptom onset, and what you can see is that this follows nicely to for what we see with other tick-borne diseases, and when people are most likely to be bitten by Lone Star ticks, with peaks being between May and September. Next slide. So there are 4 states that account for over 50% of all the reported cases of ehrlichiosis in the United States. That includes Missouri, Arkansas, North Carolina, and New Jersey. As you can see from the distribution here, this does follow pretty closely to what we know of where we find Lone Star ticks. Next slide. And I just wanted to show the comparison to the distribution for Lyme disease. And so there are some states, I have the list here of the high incidence ehrlichiosis states. The ones in bold are the ones that are also considered high incidence Lyme disease. And you can see there is some overlap, but for the most part, the states most impacted are not those that overlap with high incidence Lyme. Next slide. So our team was curious of healthcare provider knowledge of ehrlichiosis specifically. Next slide. And so this is work done by Sydney Adams, who's a former ORISE fellow on our team here at CDC. And she was curious to understand the knowledge among healthcare providers for ehrlichiosis specifically, because there have been previous studies looking at tick-borne disease more broadly or rickettsial diseases, but she was most curious about ehrlichiosis. Next slide. The primary objectives were to understand what healthcare providers know about ehrlichiosis and the other tick-borne diseases that occur in their area. Do healthcare providers know the best practices for diagnosis and treatment of ehrlichiosis? And does this knowledge vary by practitioner specialty and their geographic region? Next slide. To address these questions, we used a Porter Novelli survey, a 2024 doc styles that was issued last fall, that was administered to healthcare providers across the country using an online, administered online. Next slide. So this shows the distribution of the 1,502 respondents to this survey. That included 36% were from the South, with roughly 20 to 22% from the West, Midwestern region, and Northeastern region split. Next slide. Of the roughly 1,500 respondents, 66.6% of them were primary care providers, and the remaining was split between pediatricians and nurse practitioners and physician's assistants. Next slide. I'm just going to present 5 of the questions asked in this survey. The first one was to understand the awareness of tick-borne diseases in the healthcare provider's practice area. So the question was, which of the following diseases spread by ticks occur in the area where you practice? We, of course, asked about ehrlichiosis, but also Lyme disease, a number of other rickettsial diseases, and babesiosis. Next slide. What we found is we did see some geographic variation, and that in the southern region, which does contain some of the majority of the high incidence ehrlichiosis states, only 23.3% responded that ehrlichiosis was a concern in their practice area. Next slide. This map shows highlighted in blue just the states that are considered high incidence for ehrlichiosis. And in these states, we found that 86.8% responded that Lyme disease was a concern in their region for their patient population, while only 40.6% replied that ehrlichiosis was a concern. Next slide. The next question was about the confidence the healthcare providers had in their ability to diagnose and treat ehrlichiosis. So we asked how confident they were in their ability to diagnose and treat, giving them a range from very confident to not confident at all, and also trying to capture if they had knowledge, if they were aware of the disease at all. Next slide. What we found was less than half of the healthcare providers reported that they were either very confident or somewhat confident in their ability to diagnose and treat, and 8% of nurse practitioners in the PAs surveyed answered that they had not heard of ehrlichiosis. Next slide. The third question here is asking if their knowledge of empirical treatment. So if you suspect that your patient has ehrlichiosis, what steps would you take next? The correct answer here is to test and to treat empirically. Next slide. And what we found is roughly 50% of primary care providers and pediatricians answered this question correctly, but we saw a decrease in the number of people who answered the question correctly that were nurse practitioners and PAs at only 38.1%. Next slide. When asked about knowledge of diagnostic testing for ehrlichiosis and which diagnostic test and corresponding specimen provided the most accurate diagnosis for ehrlichiosis, the correct answer being both PCR of acute whole blood and serology of paired sera, which is the gold standard. Next slide. We found again less than half of the practitioners reapplied with these correct answers. And so what you can see is there's also a pretty marked difference between those that answered that PCR was a preferred method versus paired serology. The other noteworthy thing on this question is that over 50% of the nurse practitioners and PAs answered that they did not know the correct diagnostic test for ehrlichiosis. Next slide. The final question here we'll go over is the treatment of ehrlichiosis. So which antibiotic is the recommended treatment for patients of all ages with ehrlichiosis? And we went over this already, so I hope you would all answer this one correctly. Next slide. So the correct answer being doxycycline. And what you can see is roughly 67% of primary care practitioners, 61% of pediatricians, and then 53.7% of nurse practitioners and PAs were able to answer this correctly, with still a significant portion that answered that they did not know. Next slide. So in summary, we found that knowledge about ehrlichiosis is limited. It seems that regardless of where healthcare practitioners live and practice, they in general seem to be more concerned about Lyme disease for their patients than some of the tick-borne diseases that may actually be endemic and at a higher risk for their patient population, such as ehrlichiosis. And that fewer the providers selected these other tick-borne diseases in areas where maybe Lyme is not high incidence, but other tick-borne diseases are at high incidence. Next slide. And that the knowledge across the provider type was low, but when we looked at nurse practitioners and the PAs in this survey that got all 4 questions correct, it was only 16% of those respondents. The gaps remain in knowledge on the treatment of ehrlichiosis with doxycycline, testing and interpretation of these results, and these gaps seem to be larger for nurse practitioners and PAs. Next slide. So our team has developed training for ehrlichiosis and anaplasmosis. This is a free continued education that's available on CDC Train. It was launched in 2022, and within the first 2 years, we had around 500 individuals that were awarded credit. We do think, compared to some of the other trainings available on the CDC website, that this is a more underutilized training tool. So I would like to encourage all of you, if you would like to learn more about ehrlichiosis and anaplasmosis and the diagnosis and treatment of these diseases, to please visit CDC Train, and you can also get your free CE credit with this training. So we are working to try to reach the healthcare providers and increase the knowledge of ehrlichiosis. Next slide. And I'd just like to thank Sydney Adams, who actually led this study, and the former ORISE fellow on my team, for all of her great work, and the other members of the Rickettsial Zoonoses branch. Thank you.
Thanks for this presentation, Dr. Sauser. And thanks again to all of our presenters today. Next slide. Oh, you're on the right slide. Okay, so we have time for a few questions. As a reminder, if you have a question, please use the Q&A feature to send in your question and include the presenter's name or the topic. So let's get started. All right, let me scroll to find. Okay, so I think the first question that came in was for the tularemia presentations. And if you can answer, please let me know. What samples were PCR positive in the case of the harbor seal for F. tularensis?
That's a great question. The harbor seal, we had multiple specimens positive. I don't have them all written down. Diana, do you remember? I remember at least the lung was positive.
So lung was positive, the lymph nodes were positive, the brain was positive on PCR, and I know they tested most of the tissues that were submitted, and all of them came back positive. There may have been like a liver positive too, as my recollection. So, but definitely lymph node, lung, and brain.
Thank you. And I think this question is for Dr. Platt. What were the outcomes of the patients with tularemia? Were they, sorry, sorry, I'm trying to navigate the question. Were there antibiotics that would have covered the organism before diagnosis was made?
I think that question is actually for Dr. Olteen.
Okay.
Yeah, so all 3 patients that I mentioned in the presentation recovered and were eventually treated for tularemia. In advance of diagnosis, I don't believe any were on appropriate treatment for tularemia. So the appropriate treatment required the diagnostics that were performed.
Great, thank you. Okay, And so, keeping on this topic, in the United States, which species are most often linked to tularemia infections in patients with known wild animal exposure? Have there been any trends or changes in the species most commonly associated with tularemia diagnosis?
And I can respond to that. So in the United States, the species that are most commonly associated for wild animal exposure would be sort of small land mammals, so lagomorphs, rabbits, and hares, and then rodents. So it would include rabbits, beavers, muskrats, squirrels, and voles. I think Dr. Rolteen highlighted that marine mammals are sort of a newly identified source of tularemia, but still sort of the minority of cases.
Thank you. Okay, I'm going to skip to Ehrlichiosis if I can find a question, make sure we have time to jump to that topic. Ehrlichia scheffensis was found in Asian longhorn ticks in Connecticut. Do we know whether they are a competent vector?
Yeah, I think this is science that has just come out identifying Ehrlichia scheffensis and longhorn in Connecticut. I don't know about the competent vector. I think I'll say generally we're not too concerned given longhorn ticks don't appear to be as aggressive human biters. And so we don't have a report that I know of a human infection from Ehrlichia scheffensis from a bite from Asian longhorn ticks. Yeah, I think it is a hot topic at the moment and definitely a question.
Okay, thank you. For you again, Dr. Salzer, has there been any evidence or research into antimicrobial resistance development for ehrlichiosis infections in conjunction with the healthcare practitioner responses of treating patients without test results?
Yeah, there's no evidence of resistance, antimicrobial resistance, in really any rickettsial agent, which is good news. I think what the practice of possibly treating without testing, I personally think is maybe a consequence of that acute serology we expect to be negative. And I think healthcare providers possibly in an area where they may see a lot of rickettsial disease may treat knowing that acute serology will be negative, and then have the challenges of getting the convalescent. And so very few, like about 2% of our cases reported through national surveillance are actually confirmed. And that is partially because of the challenges of getting that both the acute and the convalescent serology. And I think practitioners often, they're focused on treating the patient, and if they are highly suspicious of it, they may prioritize that.
Thank you. And I'm going to read a question that has a response from our CDC colleague in the Q&A, but I'll just read it so that it's captured on the recording. Does doxycycline cause tooth discoloration in children whose teeth have yet to erupt? And thank you, Gilbert, for providing an answer. He says no visible dental staining in children treated with doxycycline for suspected Rocky Mountain spotted fever. He actually added a publication link if you guys want to look at that. Okay. Looking for another question, jumping back to tularemia. If you can answer, why is tularemia concentrated in the Southeast and Mid-Plains?
I can comment a little on that. I think it's probably a combination of sort of the environmental conditions that are conducive to growth of F. tularensis and the presence and prevalence of infection in biting arthropods and mammals, and then human behavior that puts people in contact with arthropods and mammals, so things like hunting.
Great, thank you. And I'm going to go ahead and read another question, and it looks like there's an answer there too, so I'll just read it, and if you want to add anything, you can. For the stranded animals that had Francisella infection, was the infection responsible for the stranding, or was it coincidental? What was the cause of death? And Diana, I don't know, maybe you want to come off of mute and answer the question. The answer is also in the Q&A. But it reads, yes, both the harbor seal and the sea otter had septicemia and intralesional gram. And these are words that I cannot pronounce. So Diana, you can help me out. Coccobacilli and coronary thrombosis. The sea otter also had necrotizing pneumonia.
Yes, that's correct. Thanks for jumping in there. I had a hard time getting my microphone off.
Okay, no problem.
And just a note too that tularemia has also been documented in belugas up in Alaska too. So
thank you. Okay, we had another question for Dr. Sauser, and I see that you answered it in the chat, but I'll read it aloud. Was awareness of human granulocytic anaplasmosis queried as well? And the answer that Dr. Sauser provided was not in this most recent study. Oh, but then we have a colleague that says yes, anaplasmosis was included in the study. So let me know if you want to have any additional comments on that, or we can move on. Thank you for providing answers in the chat. That helps us to get to more questions. I'm going to see if we have any other questions.
Yeah, so I can add, we did ask about anaplasmosis when we looked at geographic region, but not looking at the healthcare provider knowledge on the treatment and diagnosis.
Thanks. Okay, and also for you, Dr. Sauser, what is the risk of ehrlichiosis relative to Lyme disease in states where ehrlichiosis is common? You guys are killing me with these words. Since B. burgdorferi is more frequently detected in I. scapularis than Ehrlichia in its vectors, are there areas in the U.S. where ehrlichiosis is a greater risk than Lyme disease, even given the difference of prevalence of the pathogens in the ticks?
Okay, I'm going to try. I'm looking for the question in the chat here
So this
to
is
help
from
me.
this is from Riley Brennan. If you can see the question, we can give you time to find it because it is a longer question. And sometimes the questions come in and you have to refresh the new post. But yeah. I can move on though while you're looking for it. But if you do find it, it's from Riley Brennan and it says for Dr. Sauser. Okay, I'll move on. For the pinniped that was positive by PCR for tularemia in the brain, were there gross or microscopic lesions?
yeah, and this is Diana, and I was working on typing an answer to that. There was no actual samples taken of the brain. There was a culture swab that was PCR positive. So there was no histopath conducted on the brain sample of the harbor seal. For the sea otter, there was a brain sample taken and histopath was done on that brain, and there was no noted pathology in the brain.
Okay, thank you. And Dr. Sauser, if you haven't found that question yet, I can move on if you haven't.
Yeah, I can see it. No, it's a good question, and I think so. There are certainly areas where ehrlichiosis is of greater risk to people than Lyme disease. So some of the high incidence states like Arkansas and Missouri, Ixodes scapularis exist, but Borrelia is not as common, and where there's high density of Lone Star ticks. And so these are also areas where we know a lot of people there's a high burden of alpha-gal syndrome, so people are being bitten by Lone Star ticks more often. And I think the other thing just to note is that the difference in the vector. So you do have Ehrlichiosis occlurensis that's transmitted by black-legged tick in Minnesota and Wisconsin. And so you don't see, it's not as prevalent among the tick population, which might be why we have fewer cases, but it's also, there's some challenges in surveillance and detecting it.
Thank you. That's all we have time for the questions. So if you have other questions, and thank you for sending these good questions over to the Q&A box today. We've included our presenters' email addresses on this slide. A video of today's webinar will be posted within 30 days. Next slide, please. And please join us for the next ZOHU webinar on Wednesday, September 3rd. Thanks again for joining, and this will end today's webinar. Bye.